endeavor to end the AIDS epidemic, the work ahead will be in the hands of these young researchers. They're not only the voice of the future, they are also the movement of today. Some of us are not so youthful and have been doing this work for a long time, decades in fact, since the early days of the epidemic. I'm a physician and was working in London and then in Africa in the 1980s, and we lost an entire generation from HIV as we struggled to understand this epidemic and what to do to stop it. The road to now, to this moment, has been long and hard, but we've witnessed incredible breakthroughs from scaling up of antiretroviral therapies to the game changer PrEP. This progress has come through collaboration and good leadership. Collaboration has helped us set ambitious targets and to achieve real progress, progress based on human rights, an approach that came out of the AIDS conference here in Mexico City in 2008. And we've come here together to IAS 2019 to continue this collaboration, to put science into practice and meet the specific needs of those most affected, so no one is left behind. Now, allow me to point out some highlights of the program. Well, what about dolutegravir, a neural tube signal, which we heard about last year? It gave us concerns about how it would affect dolutegravir global rollout. Here in Mexico, we'll see the latest data from Botswana and elsewhere, and the updated recommendations from the World Health Organization on dolutegravir and its use in women of reproductive potential. Linked to this is the need to better integrate HIV and sexual and reproductive health. And we will have further data from the ECHO trial, which looked at different modalities of contraception and HIV risk. We'll also hear about new tools and new opportunities in prevention, including data using TAF as PrEP and the first ever human trial of an HIV prevention implant, a potential game changer. We'll have data on new drugs in resource-limited settings and updates on studies that challenge the daily 3-drug therapy paradigm. And what about cure? That agenda started here in Mexico at AIDS 2008. And there'll be the latest on broadly neutral antibodies and data to support a phase 3 vaccine trial. However, ending the HIV epidemic will take even more than the excellent science you will hear this week. It will also take leadership. We live in a world where leadership seems to be becoming more and more conservative, narcissistic, populist and inward-looking. Leadership that can disregard human rights and use racism, homophobia and ignorance as political currency. We need leadership that understands the importance of science, the importance of meaningful engagement with those most impacted by the epidemic and who can stand up against discriminatory and stigmatizing laws and legislation. Leaders need to understand that the right to health is non-negotiable and should not compete with other funding priorities. We need to ensure that all those affected by HIV should be able to access health care as a fundamental human right, and that is how our success will be measured. Now, in achieving success, we should not forget the efforts of individuals. With that in mind, I'd like to take a moment to remember our friends and colleagues who we've lost this year. Those losses are forever felt in our community. And to celebrate their lives, we've set up a memorial wall, and we invite you to add to those names of those you have lost to help honor their efforts and contributions. 50 years ago, science, leadership, and collaboration put a man on the moon, and I hope that this week, IAS 2019 will be another small step towards the giant leap of ending the AIDS epidemic. Thank you all for your time and for your commitment, and I wish you a very happy conference. Now it's with the greatest of pleasure I hand over to your local scientific chair. Please join me in welcoming Brenda Crabtree Ramírez.
Buenas noches y bienvenidos sean todos ustedes a la Ciudad de México. Secretario de Salud Jorge Alcocer Varela, honorables invitados, autoridades del gobierno, miembros de la Junta de Gobierno de la IAS, bienvenidos sean todos. Dado que este es un evento internacional y que el idioma oficial es el inglés, me disculpo por continuar mis palabras en inglés. I'm pleased to welcome everyone to Mexico City for the IAS 2019. In 2008, Mexico hosted the International AIDS Conference, and it was at that conference where for the first time a member of the sex worker community spoke on a plenary stage. It was there where the director of Mexico's HIV program, Ciencias, announced that he was gay, married to another man, HIV positive, and called our country to approve same-sex marriage. The Mexico City government approved same-sex marriage the following year, making it the first place in Latin America to legalize it. Since then, many things have changed. Mexico, in many ways, has been a pioneer in the HIV response with programs like those in Clínica Condesa and the Instituto of Health, paving the way forward in addressing the needs of the most vulnerable people in Mexico City. We have also seen recognition of LGBTQ rights, the direct result of brave actions carried out by community activists, advocates, scientists, and many more across the region. Sex work is more visible and even become legal in many countries in Latin America, and there are laws that prohibit discrimination on the grounds of sexual orientation or HIV status. More recently, governments now allow people to change their name and their gender on official documents. However, Latin America is the most social, economically uneven region in the world, and so progress has been also uneven. What's more, the gains and progress in the fight against AIDS of the last decade appear to be under threat by political and economic shifts across the continent. To be frank, the HIV epidemic is far from over, and many challenges lay ahead. Despite the successful scale-up of ART in Latin America, AIDS-related mortality has barely changed in the last 20 years, and late diagnosis is still way too common. HIV numbers of new diagnoses in adolescent MSM and in women in Mexico and overall in Chile, Bolivia, Guatemala, and Costa Rica. And what about PrEP? Rollout has been extremely slow. Some of the challenges are due to deep social and structural barriers. Nearly 4 out of 5 transgender people murdered across the world between 2008 and 2015 were killed in Latin America, with the highest number in Brazil and Mexico. Moreover, our region faces alarming levels of gender-based violence. Each day, 9 women in Mexico are killed. High levels of violence and stigma remain significant barriers in the global HIV response. And we face newer challenges, including massive migration and humanitarian crises like in Venezuela. More than ever, we need regional research to answer our own questions unique to our region. As most of you know, Latin America is underrepresented in most HIV clinical trials. Hosting the conference in Mexico allows us the opportunity to ask some of these critical questions. What approaches makes the most sense to care for people living with HIV passing through unstable settings? Why is incidence among young people in the region going up instead of down? How can we make HIV programs more sustainable? Mexico might have different ways of responding to these challenges, but the important thing is that we, as a country, we keep on asking these challenging questions. Now, many of you might not have heard of me until tonight. The fact that I am a woman, a younger HIV researcher, and assuming the role of local chair is a testament to how the IIS and our collective HIV community has supported the diversity and equity in science and leadership. Which is an example of what is needed globally. I'm honored and proud of this tremendous opportunity, especially as a daughter of 2 girls. It is you, the people in this room, and the outcomes of this week will help make sure my children and future generations can grow up in a world where they are free to live how they want and to be who they are without judgment and stigma. Globally, we must unite to face the challenges of deteriorating human rights climate, repressive and punitive national laws, increasing xenophobia and social exclusion, and the widening gap between those with and without access to health services. We must use this moment to demonstrate our resilience. I, for one, look forward working with you all to demonstrate our resilience here in IIS 2019. It is the same resilience that has led us to one of the most extraordinary public health responses in history. So let us all enjoy the next 3 days together as our colleagues present novel science on HIV prevention, treatment and cure, and as we strive to put the science into action. We are thrilled to have you here. Together, we can continue to make the difference and work to end this epidemic. Mil gracias, que tengan una excelente conferencia y una maravillosa estancia en la Ciudad de México. Thank you and have a wonderful conference and a wonderful experience here in Mexico.
Ladies and gentlemen, please welcome to the stage Mr. Luis Adrian Quiroz. Luis Adrian Quiroz is a gay man living with HIV. For 18 years, he has devoted himself to promoting comprehensive care and treatment for people living with HIV, defending human rights, and fostering the JIPA principle. He is General Coordinator of the Network of People Living with HIV for the National Institute for Social Security, co-founder of the Access Network, and a member of the National AIDS Council and coordinating board of REDLA, the Latin American Network of People Living with HIV. He was part of the Mexican delegation at 4 UN high-level meetings on HIV and has participated in several IAS and international AIDS conferences.
Hola, buenas noches, bienvenidos a todas y a todos. La siguiente parte es en inglés. Me disculpo con los compañeros mexicanos y compañeros de Latinoamérica, pero como bien lo dijo la doctora Brenda, es un evento internacional y damos respuesta en ese sentido. I want to thank the organization for the IAS 2019 conference for the opportunity to be here representing the Mexican community this afternoon. I will take this opportunity to warmly greet and welcome all participants. These coming days will surely bring intensive and fruitful work, and will allow us to learn about the recent scientific advance that has been happening in the last 30 years will contribute a fundamentally advance toward the eradication of the HIV pandemic in the near future. This progress has been possible in the political will, as well as as the participants of the community members, especially those living with HIV. The above was verified last year in the framework of the International AIDS Conference held in Amsterdam, when we saw that it's possible to guarantee access to innovative medicine for treatment initiation, reducing the access gap to health and the had previously excluded large regions in the planet, particularly in the sub-Saharan Africa. Nowadays, living with HIV and having a regular life is possible when adequate policy to access to treatment are established in our countries. On the other hand, the news about the inclusion of PrEP as a public policy in different countries have several tries of possible vaccines, among other topics. Tell about us in advance in the control of HIV in the world, the encourage of efforts. Currently, the United Nations established several evaluation measures to control this pandemic. On the most widely accepted, the 90-90-90, with which aims to nearly 90 of people which know their status, which 90 of these as treatment and 90 of them and biological control. But from the experience for those of just living with HIV, we know what happened in our bodies and the limitation of the health service. Today, we want to call to reconceptualize the third 90. Repeat, today, we want to call to reconceptualize in this 90, in addition to viral suppression, is necessary to include the attention of comorbidity and adverse effects associated with prolonged medication intake, more than 30 years now taking the toll on. And infection known as syphilis, TB, renal failure, and hepatitis C, among others. This reconceptualize requires redoubling for efforts and activities. We must keep our word of intensify your participation in the design, implementation, monitoring, and evaluation of public policies directed to people living with HIV, and thus honor compliance for the GPA principle. In the current regional scenario, some backward policy, such as those aiming the preventing the announcement on different gender expression for sexuality in recent years in America Latina, are cause for deep concern. Some governments in the region, in addition to showing little interest in the issue, have generated change in their policy that weaken national programs of the control of HIV and AIDS, increasing the stigma and discrimination, undermining the work of the civil society. These changes have caused, among other things, antiretroviral storage. Argentina, Brazil, and even Mexico are examples of how change in the policy can result in the breakdown of these systems. The most telling examples are the situation in countries like Venezuela, Nicaragua, resulting in deaths caused to a total abandonment of the HIV control policy and the human rights violations. That's from us all. We cannot continue this complicity, remaining this silence. I cannot continue with referring to the Mexican case. Also, we share the commitment on the failure against corruption undertaken by the new federal government. The improvement of health service must be urgently accompanied by action to provide care and treatment and comorbidity and co-infection for people living with HIV who receive with care through Mexican Popular Health Service, Al Seguro Popular, not doing to implicit discrimination for us. I insist, we must reconceptualize for the third 90 the guarantees equal attention for the all comorbidities. The Mexican civil society organizations extended this hand for the government of Mexico to resume or join work, which was interrupted 6 months ago, meaning 6 months without preventive action or community HIV detections. On behalf of our community, We based where President Andrés Manuel López Obrador to build a model HIV policy for Mexico in collaboration with all populations, women, gay men, men who have sex with other men, adolescents, trans women and men, injecting drug users, sex workers, persons private of liberty, girls and boys who living with HIV or the affected for this epidemic. This is the only way the joint work between government and community for Mexico, Latin America, and all the all nations to effectively and ethically responsible for the historical challenge of continue the epidemic for 2030. We want to need another choice to build the rights to health without discrimination for all. We need a solution for the medical shortage in the regions. Es urgente garantizar la atención igualitaria en toda América Latina y que las personas que vivimos con VIH hoy en día sean atendidos con todas las comorbilidades sin ningún tipo de discriminación. Muchas gracias.
Ladies and gentlemen, please welcome to the stage Mr. Alejandro Brito. Mr. Brito is the director of the supplement to the Mexican newspaper La Jornada, called Letter S, Health, Sexuality and Society. The supplement has been dedicated to disseminating information on HIV and AIDS for more than 20 years. Alejandro is also director of the civil organization Letter S, AIDS, Culture and Daily Life, where he combines his work as a journalist and an activist to defend the rights of LGBTI people and people living with HIV. In recognition of his defense of human rights, the National Council to Prevent Discrimination granted him the National Recognition for Equality and Non-Discrimination Award in 2018.
Muy buenas noches, tengan todas y todas ustedes. Good evening to everyone. Community mobilization efforts have been crucial in the response to the HIV pandemic. Civil society organizations play a key role in reaching those people and communities most affected by the epidemic that don't have access to government services due to their conditions of marginalization and discrimination. But the decline in funding from international donors and from national governments is jeopardizing that essential role. Up until very recently, Mexico had stood out as a model of social contracted and public funding to civil society organizations. But due to the withering cut of those public funds, Mexico is moving away from that model. While global efforts aim to accelerate the response to HIV, Mexico is slowing it. Denying support to civil society and community organizations could trigger a number of new infections. Latin American governments must take responsibility for funding prevention services provided by those organizations. They can afford it. We are an essential part of the response to the HIV epidemic. We know how to raise the voice when necessary, but we also know how to collaborate to find solutions. Let me give you an example. In response to the threat of antiretroviral drugs shortage due to a change in the medicine purchase policy as part of Mexican government's fight against corruption in the health system, a group of physicians and activists submitted to both health and finance authorities a new treatment strategy. Fortunately, the government accepted it. As a result, we get, first, the simplification of treatment schemes by introducing the best available antiretroviral drugs in the world. Second, a reduction in treatment costs with saving of $70 million. Mexico pays the highest prices for antiretroviral in Latin America. Third, a way to confront the growing problem of viral resistance to the treatments. With this new strategy, it will be possible not only to attend a greater number of people, but it will also be feasible to put an end to the perverse practice of allowing the pharmaceutical companies control the flow of antiretroviral public purchases. This is an example of the kind of things that can be achieved when key stakeholders work together and the person is placed at the center of the decisions beyond particular or commercial interest. On the other hand, we need to boost the activism against hepatitis C, which is particularly affecting HIV people. Unless we do it, this epidemic threatens to reverse the achieved goals in the control of the HIV epidemic. Hepatitis C is curable. It is urgent to make its treatment available to those who need it. Technological and scientific advances, on the other hand, are giving us a new opportunity to stop HIV epidemic. Those countries that have adopted PrEP have achieved reduction in the number of new infections. PrEP must be adopted as a public policy. We cannot afford to miss this new opportunity. Mexico and other countries of Latin America can afford it. Make PrEP available now. Latin America is the world's most violent and unequal continent. States in the region have failed to provide security and well-being to their inhabitants. Hence, the growing waves of migrants, displaced people, and refugees. If people's lives are in danger, no wall will be enough to stop the determination to look for safer places or the treatments they need to live. In some countries like Venezuela, there is a forced exodus of people living with HIV due to the collapse of the health services and the lack of treatment. In an effort to survive, these people abandon their places of origin. Any person fleeing their country for fear of losing his or her life, either to the violence of lack of treatment, should receive international protection. In particular, priority must be given to protect transgender women applying for asylum. Deporting trans women and people with HIV in this situation is nothing else but a death sentence. If we are really committed to leave no one behind, we should make the commitment to provide antiretroviral treatment to people with HIV, regardless of their immigration status and without any restrictions. In particular, we must guarantee treatment to people with HIV deported as a result of Donald Trump's inhumane immigration policy. We cannot become accomplices of his hatred, xenophobia, and racism. Stop migrants and refugees criminalization. Stop HIV criminalization. Finally, the scientific community is united once again to expose to the world the latest advances in HIV research. That will allow us to take the best decision in order to stop the epidemic. We must also gather all our efforts to bring scientific achievement to the people. Let's do it. Thank you very much.
Ladies and gentlemen, please welcome to the stage Quarraisha Abdool Karim. Quarraisha Abdool Karim is the Associate Scientific Director of the Center for the AIDS Program of Research in South Africa, CAPRISA for short, Professor of Clinical Epidemiology at Columbia University and Pro-Vice Chancellor of African Health at the University of KwaZulu-Natal. She is also the UNAIDS Special Ambassador for Adolescents and HIV. Her research over the past 3 decades has focused on the evolving HIV epidemic, factors influencing the acquisition of HIV in adolescent girls, developing and evaluating women-initiated HIV prevention technologies, preventing deaths in HIV/TB co-infected people, and training and capacity building to enhance responses to the HIV epidemic.
We are an organization called the International Indigenous Working Group on HIV and AIDS. We stand in solidarity with all Indigenous peoples and communities responding to HIV and AIDS, and we take the stage tonight to tell you that HIV and AIDS affects everyone, and Indigenous populations matter. Accurate data and Indigenous-driven research are essential. Getting to zero means addressing equity. We demand Indigenous health and rights to be included in all policy. Access to treatment should be guaranteed for all, including Indigenous peoples. Indigenizing the prevention movement is essential. Indigenous community-based responses and leadership must be supported, and we must ensure collective leadership and accountability. But for all this, financing of a comprehensive Indigenous HIV and AIDS response is paramount. We call upon national governments, international organizations, private institutions, and funding entities to take action and implement our demands. Indigenous peoples deserve healthy and thriving communities. We have never been silent, but you have not heard us. The world cannot get to 90-90-90 without Indigenous peoples. Join us in solidarity at iiwgha.org on Facebook and Twitter. Hey, hey, hey!
Ladies and gentlemen, please welcome to the stage Quarraisha Abdool Karim.
Distinguished guests, friends, colleagues, the indigenous people of Mexico and other parts of the world, it is indeed a great honor and privilege to address you at the opening of the IAS 2019 conference in Mexico City. I thank the people of Mexico City for their warm welcome and generous hospitality, and the organizers of the conference for this opportunity to address you on the global response to HIV, no time for complacency. Today, the global HIV epidemic is widely viewed as triumph over tragedy. This stands in stark contrast to the first 2 decades of the epidemic, when AIDS was synonymous with fear, pain, and death. Indeed, we have made great and unprecedented progress on treatment and PMTCD since the first reported cases of AIDS in the early 1980s, to the extent that the AIDS response has now become a victim of its successes. There is an impression that the epidemic is no longer important or urgent. But have we turned the tide on HIV sufficiently to warrant directing our attention and investments elsewhere? Highly effective treatment through an array of about 30 new antiretroviral drugs has given people living with HIV an almost normal lifespan and instilled hope in high-burden communities. Activism and advocacy played a key role in ensuring global access to treatment. Simplified, low-cost, 1 pill a day, 3-drug combination regimens with minimal side effects are now widely available and continue to be improved on. The Global Fund to Fight AIDS, TB, and Malaria, and the United States President's Emergency Plan for AIDS Relief supports global access to life-saving treatment in poor countries and has helped to increase treatment coverage from about 2 million people in 2005 to about 24 million people in 2018. AIDS is now a chronic manageable condition with great individual level benefits associated with viral suppression, including non-transmissibility of the virus, or U equals U if you prefer. While we've made great progress on initiating infected individuals on treatment, much more remains to be done to sustain the gains achieved thus far and ensure that these are not reversed. We've had great success with PMTCT and are moving towards potential elimination. But progress has stalled. There has only been an 8% decrease in new pediatric infections in the last 2 years. Last year, there were 160,000 new pediatric infections, very far from the target of 20,000 by 2018. If we don't pay attention with renewed attention and resources, instead of elimination, we will have a rebounding pediatric epidemic on our hands. It is increasingly difficult to achieve the last mile of elimination, and now is not the time for complacency. It is time for increased attention to the mother-infant pair with a unique opportunity to not just eliminate pediatric HIV, but to improve maternal and child health in low and middle income countries for all individuals. Nearly 5,000 new cases of HIV infection occur each day, defying any claim of a conquered epidemic. The estimated 38 million people living with HIV, 770,000 AIDS-related deaths, and 1.7 million new infections in 2018 remind us that HIV remains a serious global health challenge. Millions need support for lifelong treatment, and millions more still need to start antiretroviral treatment, many of whom do not even know their HIV status. The continued high maternal death rates, barriers to access to treatment for children, and the transitioning of infants and children exposed to and are born with HIV to adolescents are growing and emerging challenges that need to be addressed so as not to reverse the gains made to date. While we have evidence and good policies, we continue to face implementation challenges. People living with HIV have more than a virus to contend with. They must cope with the stigma and discrimination that adversely affect the quality of life and undermine their human rights. A further crucial challenge looms large: how to slow the spread of HIV. Preventing HIV is and remains a challenge. The steady decline in the number of new infections each year since the mid-1990s has almost stalled, with little change in the past 5 years. Between 2000 and 2018, we've seen only a 16% reduction in new HIV infections. HIV continues to spread at unacceptable levels in several countries, and especially in marginalized groups such as men who have sex with men, sex workers, people who inject drugs, prisoners, and transgender individuals. Of particular concern is the state of the epidemic in sub-Saharan Africa, where young women aged 15 to 24 years have the highest rates of HIV new infection globally, almost 1,000 new infections each day. Their socio-behavioral and biological risks, including age-disparate sexual coupling patterns between teenage girls and men in their 30s, limited ability to negotiate safer sex, genital inflammation, and vaginal dysbiosis are proving difficult to mitigate against the background of structural challenges of, amongst others, poverty, gender-based violence, and gender power dynamics. Current HIV prevention technologies, such as female condoms and pre-exposure prophylaxis, have had limited impact in young women in Africa, mainly due to limited access and low uptake and poor adherence. Yet, reducing HIV in young women in sub-Saharan Africa could change the course of the epidemic in Africa and reverse current poor global progress in HIV prevention. The unmet needs of people who use drugs globally and the extent of the opioid epidemic in North America are major causes of concern. The world is still failing in its goal to reduce new infections among people who inject drugs. Yet we have compelling evidence on the benefits of needle syringe programs, maintenance therapy with methadone, and how to minimize deaths from overdose in mitigating the consequences of unsafe substance use. Yet barriers to access and safe use continue amidst growing unnecessary, harmful criminalization and excessive human rights abuses on every continent. There is no room for complacency when so much more remains to be done for HIV prevention and treatment. The task of breaking down barriers and building bridges needs greater commitment and impetus. If the United Nations Sustainable Development Goal target of a 90% reduction in HIV incidence by 2030 is to be met, now is not the time to slow down the global AIDS response. We have a better understanding of the complexities and unique characteristics of the HIV epidemic at a local level and know that a one-size-fits-all approach is not appropriate. We have to know and understand the unique conditions at a local level so that a meaningful, locally appropriate response can be crafted and implemented. The social mobilization and activism and advocacy that characterized the early HIV response are even more critical now. Stigma remains a major barrier to access to services, and services are not meeting the needs of those who most need to be reached. We need to invest more in human-centered approaches, and much can be learned from patients, peers, clients, and communities. Communities are central to the response and have the knowledge to address the many challenges being encountered at a local level. We need to invest more in communities and creating an enabling environment for this to be realized. We know from research and country-level data that 90-90-90 on its own will not end the AIDS epidemic. More effort and investments are needed to support ongoing treatment, address comorbidities including TB, increasing testing and treatment, deliver effective prevention and sexual reproductive health programs to those most at risk, and expand the available prevention strategies and meet the testing gap. We need to continue to invest in enhancing responses through innovation. Over the next several years, we can look forward to outcomes from trials that are currently evaluating long-acting, slow-release ARVs for prevention and treatment in the form of 2 to 3 monthly injections and annual implants, passive immunity through combination broadly neutralizing antibodies, and point-of-care diagnostic tests. To end AIDS, we need a vaccine and a cure. Until then, we need to do our best to control the spread of HIV and minimize morbidity and mortality rates among those already infected with HIV. We are dealing with a complex challenge with no easy and quick solutions, and to paraphrase Nelson Mandela, it always seems impossible until it is done. And while we have accomplished much, much more needs to be done, and that is our task in the coming days and the coming years until we see the end of AIDS as a public health threat. Thank you very much for your attention.
Ladies and gentlemen, please welcome to the stage Luis Soto-Ramirez.
Hi. 11 years ago, as a co-chair of the 78th International Conference in Mexico City in 2008, I had the chance to welcome more than 20,000 people, friends, colleagues, activists, but the most marvelous human beings that gave us unforgettable memories. So your presence here now make us very, very, very happy. And be prepared, because we will give you all a warm and respectful treat, because what we want is to touch your soul, and obviously to learn science too. Now, it is my honor to introduce you Dr. Carissa F. Etienne. Dr. Carissa Etienne began her second 5-year term as a Pan American Health Organization director in February 2018. She has an MBBS degree from the University of the West Indies and a Master in Science degree in Community Health and developing countries from the London School of Hygiene and Tropical Medicine. Dr. Etienne began her career in her native Dominica as a medical officer at the Princess Margaret Hospital. In Dominica, she has served as a chief medical officer, director of primary healthcare services, coordinator of the National AIDS program, disaster coordinator for the Ministry of Health, and chair of the National Advisory Council for HIV and AIDS. From 2003 and 2008, Dr. Etienne was PAHO assistant director, and from 2008 to 2012, she was assistant director general for health systems and services at the World Health Organization. At WHO and PAHO, Dr. Etienne, among many other activities, has led efforts to renew primary health care and strengthen health systems based also on primary health care. Please welcome Dr. Carissa Etienne from the Pan American Health Organization.
Thank you for this introduction. Honorable Secretary of Health of Mexico, Dr. Jorge Alcocer Varela, distinguished participants, excellencies, friends, colleagues, the media. Good evening. Let me begin by thanking the Secretariat of the International AIDS Society for inviting me, and allow me to recognize the remarkable role of the International AIDS Society for organizing a wide range of activities, which includes this prestigious conference. It is a true honor to address this opening session tonight. I bring you greetings from Dr. Tedros, Director General of WHO, and his own best wishes for a successful conference. I think it deserves a clap. On behalf of WHO, the Director General and PAHO, let me also thank the government of Mexico and the people of Mexico for hosting this conference. Back again to the Americas for the 4th time since its premiere in Buenos Aires in 2001. This is, I think, a reflection of the contributions and active role played by the scientific community of this region, which I salute today in appreciation for its continuous commitment to advance the response to HIV. Research and science, alongside with civil society activism, community participation, and compliance with and promotion of human, gender, and equity rights, constitute the building blocks and an asset for the response to the HIV epidemic. Science has over the years guided innovation towards an unprecedented progress in responding to a communicable disease that until recently represented a threat to the lives of millions of individuals and a formidable challenge to families, communities, and entire societies. We have been able to reverse that situation in many countries through crafting and implementing robust public health rights and evidence-based approaches, and we should be all proud of it. However, there is much to achieve, as you have heard from previous speakers, and multiple threats to manage. Despite bold efforts, unprecedented funding, and strong political commitment, we are not on track to achieve the Sustainable Development Goal target of eliminating AIDS as a public health threat by 2030. Building on our past successes, it is time to rethink our response to ensure that we reach our HIV targets alongside broader health and development targets to which countries have committed. Universal health, which for us in the Americas is universal health coverage and universal access to health, provides a framework for a reinvigorated approach, a world in which all people receive the comprehensive health services and commodities that they need, that are of good quality without experiencing financial hardship. And when we speak about comprehensive services, we speak about promotion, about prevention, about treatment and care, about rehabilitation, and even palliative care. So, comprehensive health care. What does that mean for HIV, however? This year marks the 50th anniversary of Stonewall, a most iconic event that laid down the foundation of the LGBTI movement. I salute the LGBTI community and ask them to continue pushing for a better world, fully inclusive, regardless of gender, religion, race, and sexual orientation. I can assure you that in our region, we are taking inequity very seriously. And in fact, back in 2013, PAHO member states unanimously approved a first ever resolution to address LGBT health and the causes of disparities in access to and use of health services. No One Left Behind, one of the first and foremost guiding principles of HIV activism, has now become central to the global health agenda. What an opportunity. This fundamental overlap of perspectives, particularly when considering marginalized, underserved populations and people living in conditions of vulnerability, clearly indicates a great potential for synergies in achieving both HIV-specific and broader universal health coverage and universal access outcomes. It is very clear to me that the path to ending AIDS runs through universal health. Part of my public health journey was as an HIV coordinator in my home country, Dominica, and also as the director of primary care services and as chief medical officer, as you probably heard. But what I learned in those early days of the epidemic proved precious when in later times I was dealing with health system strengthening and the challenge to link disease-specific programs, including those addressing HIV, TB, malaria, with broader health and development priorities. Global health has now advanced along the lines of the Sustainable Development Framework, which focuses on individuals first rather than diseases, whereby universal health coverage and universal health access is indeed the key driver to achieving health-related targets by 2030. It is worth remembering that in the HIV response, fundamental objectives of the movements were the universal provision of services in line with equity and human rights principles. They set a trend followed then by other public health programs such as TB. In contrast, many voices have spelled out fears and concerns that embracing universal health may cause dilution and loss of focus for HIV and other disease-specific programs. I believe that with your vigilance, it will not, it cannot. If we look at the trajectory of the HIV response over time, I would argue that the opposite is true. The response to HIV started as an emergency to combat a fast-growing and largely unknown epidemic, often supported by external funding, that grew to an unprecedented magnitude. These responses have matured over time into well-established programs that, in order to reach their goals and targets, do require integration and sustainability to address the broad health and social needs of those individuals and the populations that are affected. It is my conviction that fully aligning with universal health coverage movement is a great opportunity for optimizing and increasing the predictability of funding, including domestic resources that already represent the largest share of HIV investments, as well as for ensuring the continuity of external assistance that is still necessary in lower income settings, even in some middle income countries, so that services do reach those at risk and marginalized. At the same time, the UHC drive on integration of services and its robust focus on the delivery of people-centered services at the primary care level would promote both programmatic sustainability and further scaling up of HIV services. Now, I am not talking about the first level of care that many of us know in our countries. It is clear that there is significant work to be done to improve the first level of care, to improve the finance and investments in our first level of care, to ensure the necessary technology that must ensure quality of care. We need to ensure the human resource capacity is there and that trained and motivated persons are serving at that level of care. We need to ensure greater quality of care. Importantly, people need to have care very close to where they live. They must also have the confidence that these services at that level have the capacity to solve their problems and to deliver the care at the highest level that they require this care. And so recently here in Mexico, we launched what is called 30-30-30, that by 2030, that governments and partners will reduce barriers to access to care by 30%, and that will increase the investment to primary health care by 30%. This is the type of primary health care that I am speaking about, not the poor care for poor people. And if we do that, we will increase efficiencies, we would be able to treat Many more people with the investments, both in terms of the external investments, but domestic investments. We have to find ways of ensuring that our governments invest more, but that we ensure efficiency. Ladies and gentlemen, I believe it is time for HIV prevention, testing, and ARV services to be fully available alongside with TB, STI, viral hepatitis, sexual and reproductive health, and non-communicable disease services at the first level of care, where the needs of affected communities can be best attended. This does not mean that we do not need the vigilance, the activism, the special approach and the special program of HIV/AIDS. We do not need one or the other. We need both. And this is my plea to you. We need both. We need well-financed and well-developed and well-researched HIV programs that intersect with a first level of care that is prepared and that can solve the problems of the communities at that level. And this, thank you very much. I need to share something with you. I came here feeling a little, I wonder how they're going to take this message, because I've been burnt before, but I'm standing there, and so thank you for the encouragement. So this is exactly the approach that we promoted in the region of the Americas, where several countries have pioneered and achieved dual elimination of mother-to-child transmission of HIV and syphilis, the rapid integration of evidence-based PMTCT measures into comprehensive mother and child health services to be delivered at the first level of care. I believe also that what is urgently needed is a quality dialogue between HIV communities and the health system planners that creates a joint working culture and a space with understanding and mutual commitments, bringing the assets of the HIV response into the universal health movement, where HIV is fully integrated into health plans. When we talk about quality of care, we are talking beyond the patient-doctor relationship. We are talking about quality that speaks to important governance mechanisms, that speak to important financing and investment, that speaks to important information gathering and analysis, that speaks to ensuring the capacity of the first level of care to deliver, that speaks to the integration of networks of delivery of care, where the first level of care is connected with the second level and the third level of care. We are speaking beyond just the interaction with the doctor-patient. We are talking about a total system that is built, organized, and prepared to deliver on the health and well-being of its people. So I believe also that we need to look at what is called health benefit packages in our region, or essential health packages as they will call them. We need to ensure that HIV prevention and treatment, control, etc., is fully integrated into these benefit packages. And we definitely need more research so that innovation will continue to improve the effectiveness of HIV combination prevention, to refine treatment regimens that could be further decentralized, develop new laboratory tools, and expand the use of integrated platforms for diagnosis and monitoring. Let me now take stock of some of the highlights of the just launched UNAIDS report. There is a mixture of achievements and challenges, as you've learned. Close to 2/3 of all people living with HIV in 2018 were receiving life-saving antiretroviral therapy, 62% globally, and in Latin America it is 61%. More than half had suppressed viral loads. 6 countries have achieved all the 90-90-90 targets. Nevertheless, testing and treatment programs in several regions are off track. Gaps in the HIV testing and treatment cascade of services tend to be larger among men, key populations, young people, and children. It is sad to mention that only 54% of children with HIV worldwide were receiving antiretroviral therapy by the end of 2018. I think another worrying news is the widening shortfall of resources. $7.2 billion short in 2018 against the $26 billion funding level that is needed. I wish the forthcoming Global Fund replenishment, I wish your meeting great success in ensuring the mobilization of the much needed resources. Over the last few weeks, we have also heard worrying news about the return of old threats, like outbreaks of the iatrogenic HIV infections, mainly due to unsafe injections and the failure of other infection prevention and control measures. Health systems need to stay extremely vigilant in order to prevent the occurrences of these epidemics. As we know all too well, that when HIV breaks through fragile and weakly enforced systems, consequences may be disproportionately disastrous. Migration and HIV continue to represent elements of great concern worldwide. In the current political and social context, marked by repeated challenges to human and other fundamental rights, declining funding and commitments, our work with most affected communities, men having sex with men, transgender people, people who use drugs, migrants, etc., becomes more urgent and more critical than ever. In this complex situation, I would like to make a plea to all partners in the HIV response, including the scientific and programmatic communities, to intensify and accelerate action. Science, evidence, and innovation must continue to guide HIV policies, programs, and investments. We must get back on track to achieve our AIDS elimination targets. Science and innovation must find solutions to both long-standing and new challenges, and new knowledge and guidance will only achieve impact if there are strong national programs and community systems in countries to implement them. I call on governments, civil society, private sector, academia, and research communities, multilateral and bilateral agencies to make this happen. Let us end AIDS by 2030 together. Thank you.
While Mexico was when in 2008, HIV was firmly placed within the human rights agenda, so let me introduce a video message from the UN Commissioner for Human Rights, Michelle Bachelet.
Greetings. First, I want to thank all of you for your work to halt the HIV/AIDS epidemic. Whether you work in a clinical environment or a lab, the research you are engaged in seeks to establish ways to prevent and heal suffering. There are so many human rights issues involved in the HIV/AIDS epidemic. There's stigma, discrimination, abuse, poverty, decriminalization of IV drug use, and in more than 30 countries in the world, still today, the criminalization of LGBTI people. But there's also the long struggle by human rights activists to undo the stigma against individuals at high risk of HIV/AIDS. I look back and see there are decades of work and advocacy to build health systems which today are far more accessible and respectful of communities, which have gained in power, though may continue to be subjected to marginalization. I see the progress we've made in ensuring that patients and activists participate in framing both policy and research and increasing understanding that global inequality in access to antiretroviral treatment is a fundamental question of social justice and human rights. I see increasing acceptance of the inalienable right to health and adequate health care for every human being. These have been essential factors in building our society's resistance to HIV/AIDS epidemics. But we need to keep pushing forward to embed human rights into health policies and into clinical practice and research. As your efforts continue to bring the world closer to a vaccine and to a clinical cure for AIDS, new questions with great impact on human rights will emerge. First, let me cite access for people and countries that are not wealthy. Pre-exposure prophylaxis is effective, but is still not widely available, even in many high-income countries such as the UK and Switzerland. We need to fix this, and we need to work on making other new treatments as widely available as possible. Second, discrimination in law. Still today, more than half of new infections are occurring among men who sleep with men, sex workers, prisoners, transgender people, and intravenous drug users. So it is essential to ensure that these at-risk populations participate in shaping policies and programs, and that countries realize the calls by UNAIDS, WHO, and others to reform laws on LGBTI relationships, sex work, and individual drug use. We need better healthcare system for prisoners. We must also pay attention to the need for pediatric formulations, not just for HIV treatment, but also for TB and other associated infections. This may be costly to develop, but it's not acceptable that so many children are still being left behind. In 2017, of the 1.8 million children estimated to be living with HIV around the world, only half were receiving treatment. Human rights activism has shaped your work in many ways, and the HIV/AIDS epidemic has had profound influence on the human rights community's approach to the right to health. I very much hope that we will continue to strengthen that partnership so that as science advances, social justice and human rights keep pace. Thank you very much.
Ladies and gentlemen, please welcome to the stage Juan Sierra-Madero.
Ladies and gentlemen, please welcome to the stage the Honorable Minister Jorge Alcocer Varela. I'm going to introduce him briefly. He will speak, he will give his message in Spanish, but there will be a translation in the slides that will be shown. Dr. Jorge Carlos Alcocer Varela is Mexico's Secretary of Health. He has a degree in medicine and a PhD in medical science from the National Autonomous University of Mexico, and he has specialized in internal medicine, rheumatology, and clinical immunology. Dr. Alcocer is an emeritus researcher in medical science of the Department of Immunology and Rheumatology of the National Institute of Medical Science and Nutrition. He is a member of the National System of Researchers and the chairman of the Subcommittee on Health of the Evaluation Commission of the National Council of Science and Technology. He has been certified emeritus researcher by the National Institutes of Health and High Specialty Hospitals of the Secretary of Health, and he has served on the editorial committees of 7 journals and has authored more than 200 scientific publications. Bienvenido, Dr. Alcocer.
Muy buenas noches. Honorable doctora Diane Gashumba, ministra de Salud de Ruanda. Distinguido señor Pavio Rosenko, viceprimer ministro de Ucrania. Doctora Carissa Etienne, directora de la Organización Panamericana de la Salud. Señor Anton Pozniak, presidente de la Sociedad Internacional de SIDA y chair de la Conferencia 2019 de la IAS. Embajadores y representantes del cuerpo diplomático acreditado en México, representantes de organismos internacionales, organizaciones de la sociedad civil y academia, señoras y señores, muchas gracias. Para mí es un privilegio estar hoy con ustedes en esta 10ª conferencia científica sobre VIH de la Sociedad Internacional de SIDA en este día. Encontré una frase perdida en un rincón de la selva chiapaneca de nuestro país. Es tiempo de ponerle una sábana al fantasma para verlo y empezar a saber cómo combatirlo. Ante ella les presento para mí lo que es todavía una urgencia. Estaremos de acuerdo que la ciencia es nuestra única sábana, la mejor que tenemos. Con ella aprendemos los mecanismos epigenéticos, inmunológicos y transicionales que nos ayudan a combatir un virus. Pero además, con la ciencia podremos actuar a tiempo. Que se escuche bien, queremos actuar a tiempo, para que cuando hagamos el diagnóstico no encontremos al paciente con niveles de CD4 aplastados por el virus. Estamos comprometidos en ello y desde la Secretaría de Salud promovemos sin descanso el diagnóstico temprano, la vinculación oportuna a tratamiento y la supresión viral mediante tratamientos efectivos. Repito, queremos llegar a tiempo y con la ciencia ponerle la sábana al fantasma. Este mensaje de compromiso, fuerza y solidaridad lo hacemos particularmente para las poblaciones clave, como ya se ha dicho, los hombres que tienen sexo con hombres, personas trans, personas que se inyectan drogas y trabajadores sexuales, entre otros. También me dirijo a la comunidad LGBTI que enfrenta discriminación y estigmatización. Nunca más hay que temer a los amigos del odio. Debemos combatirlos políticamente donde son más débiles e intelectualmente donde son más fuertes. La mejor defensa para la salud de las personas que viven con el virus de la inmunodeficiencia humana es la que previene los ataques del estigma y la discriminación. El odio hacia la diversidad sexual es el miedo que se tienen a ellos mismos y su propia suerte. Ante esto, tenemos que saber que somos un colectivo que pueden, saben y quieren darle fin a la epidemia. Como comunidad que confía en la ciencia para orientar su acción, tenemos que estar unidos para combatir el virus y para combatir el silencio del ego. Aullar con los lobos no nos quita la suerte individual de que una noche nos devore. Si se llega a tiempo, hay esperanza, y si investigamos más, lograremos poner la sábana y ver lo que aún no hemos visto. Sin embargo, si el miedo es el caldo de cultivo del odio y de la corrupción, que la esperanza sea la madre que nutra la transformación del país. El miedo monologa, la esperanza dialoga. Como lo refiere esa frase en esa selva chiapaneca, descubrir cómo golpear al fantasma será un llamado de emergencia para el sistema de salud y aportará una pieza más en el gran mosaico de un México sin transmisión materno-infantil del virus de la inmunodeficiencia humana y la sífilis congénita. El mosaico será alegre porque lo habrá hecho la gente consciente, comprometida y esperanzada que venció a las personas grises de la corrupción que acumulaban sonrisas y dinero despojando la salud de los pacientes y las personas que viven con este virus. Desde la Secretaría de Salud, hace pocas semanas, logramos que México tenga el mejor esquema antiviral para personas con VIH. Además, como ya se mencionó, esta optimización terapéutica derivó en un ahorro acumulado de 1.700 millones de pesos, resultado de la mejor colaboración entre academia, sociedad y gobierno en defensa del interés público para la salud y las finanzas públicas. El fantasma es enorme. Es tiempo de que entre todos le pongamos esa gran sábana para verlo y saber cómo combatirlo. La inmunología, por ejemplo, aporta el contraste necesario para ver dónde es mejor pegarle al espectro viral. Actualmente, los dos enfoques principales para generar inmunidad protectora son a través de anticuerpos ampliamente neutralizantes e inducción de anticuerpos funcionales a la región B1, B2 de la envoltura del virus. Estos y otros abordajes que serán tema de estos días generarán mayor esperanza para desarrollar una vacuna eficaz contra el virus. Sin duda, el desarrollo de una vacuna universal efectiva contra el virus es el mayor desafío biomédico. En este mismo sentido, la inducción de anticuerpos protectores funcionales aporta anhelo para afrontar la epidemia. Pero aún queda mucho camino por recorrer, tanto en innovación científica como en su traducción hacia políticas públicas más efectivas. Este camino pasa por lograr más oportunamente detectar y vincular a tratamiento a las personas que viven con el virus y desconocen su estado serológico. También por garantizar que todas las personas tengan acceso a servicios integrales de prevención y atención de calidad. Por eso somos repetitivos, queremos llegar a tiempo y con la ciencia ponerle la sábana al fantasma. Acceder oportunamente a detección y tratamiento del virus es un derecho básico. En México adoptamos el compromiso global para eliminar las barreras que disuaden a las personas de hacerse las pruebas de VIH y conocer su estado serológico. También las múltiples barreras que retardan el inicio del tratamiento efectivo e impiden alcanzar la supresión viral sostenida. Este compromiso incluye combatir el estigma y la discriminación hacia la diversidad sexual y de género y hacia las personas que viven con VIH. También requiere garantizar servicios de salud integrados e incluyentes y profesionales y eliminar las barreras normativas y jurídicas que dificultan todavía hoy el acceso a diagnóstico y tratamiento del virus temprano y efectivo para todos. También sabemos que en México y en América Latina existen referentes que nos dan esperanza. Enfermeras, médicos, trabajadoras sociales, investigadores, diferentes personas dentro del sector salud que trabajan en sus comunidades todos los días, voluntarios, aliados y organizaciones de la sociedad civil e internacional que han impactado positivamente a la población. Ellos y ustedes nos inspiran, así como también las personas que viven con sus familias y sus comunidades. Estimados todos, científicos y no científicos, bienvenidos a la Ciudad de México. Desde el 1 de diciembre de 2018, el México que hoy visitan tiene un nuevo rostro. En el plan de gobierno que hemos denominado la Cuarta Transformación de la vida pública del país, trabajamos por un sistema de salud universal y gratuito que garantice el acceso efectivo de toda la población a la protección de la salud. La transformación que vive el país busca revertir la esclerotización de la burocracia sanitaria que ha cerrado puertas a las poblaciones clave y a personas que viven con el virus. Es un soplo de aire fresco necesario para derribar las barreras al acceso a la prevención, detección y el tratamiento médico. Por tanto, es una acción libertaria basada en los derechos y la inclusión. La transformación se nutre del ánimo y la esperanza de que al terminar con la corrupción, la vida pueda cobrar otra perspectiva. Por último, quiero enviar un mensaje desde el corazón a las personas que viven con VIH, que nos están escuchando. Estamos con ustedes y para ustedes. No perdamos la alegría. Cualquier alegría, incluso en un estado de inmunosupresión total, es una esquina de un mundo mejor. La alegría, en palabras de Alejo Carpentier, es la consagración de la primavera frente al más duro de los inviernos. Es el olor que desprende la tierra en una tormenta de verano. Es llegar a tiempo a pesar de salir con retraso. Es explotar con los dedos burbujas de plástico. También es la paz que quitaba el miedo al poeta Juan Ramón Jiménez y le hacía escribir: me marcharé y se quedarán los pájaros cantando. Entonces con cariño les decimos: no se vayan, porque saben que se quedarán los pájaros cantando. No abandonen el tratamiento antirretroviral. Acudan al médico periódicamente, ayuden a prevenir e inviten a todos a hacerse la prueba a tiempo. No dejen de exigir sus derechos. Estamos con ustedes. Ayúdenos a llegar a tiempo. Más ciencia y más conciencia. Somos un eslabón infinito de un viaje que lleva 5 millones de años. Y estar con ustedes nos llena de fuerza y razones para seguir avanzando. Las transformaciones de nuestro país que nos han heredado lo más hermoso en nuestra sociedad se construyeron con ese impulso. Trabajemos para que sí sea. Bienvenidos a México. Siendo las 21 horas del domingo 21 de julio de 2019, declaro formalmente inaugurada en la Ciudad de México la 10ª Conferencia Científica sobre VIH de la Sociedad Internacional de SIDA. Enhorabuena y muchas gracias.
The conference organizers would like to thank all the speakers and co-chairs for their participation. The opening session is now over. We wish you all a wonderful conference and an excellent evening. As you leave the room, please remember to return your headsets at the door or give them to one of our volunteers. Thank you for your cooperation.